Good afternoon, everyone. Hello, Larner College of Medicine. Good afternoon. Before we start with the program, I do want to give a shout out to an event that I hope you've already seen, and that is in the spirit of inclusion and diversity and wellness. The College of Medicine is sponsoring an amazing dance performance at the Flynn Center on the 30th this month. It's two women who actually dance in wheelchairs, and it's apparently an amazing performance. We sponsored 100 tickets, co-sponsored by the Office of Diversity and Inclusion and the Wellness Committee, to celebrate the community and arts and diversity and inclusion at the wonderful Flynn Theater. So for the first year students, especially if you've never been there, we sponsored this for 100 tickets. The bad news is we ran out of tickets already. The good news is we just doubled down for another 100 tickets. And we will keep going if we need to. So the 30th, it's called Kinetic Light. Thank you. So, thank you, Jeannie, who keeps me on time. Okay, so the 30th, please join us for a celebration of the Larner community for arts and wellness. And for the first and second year students, I bet you'll do better on your test if you celebrate the arts for a couple hours rather than studying just that much more. So, it's really my pleasure to welcome you to the 6th annual Vito Imbasciani and George DiSalvo LGBTQ Health Equity Lecture. From a personal standpoint, it's been a true pleasure for me and my wife Jeannie to get to know Vito and his spouse George over the last year. They've generously funded this series, the first such at any medical school, with the goal of supporting the preparation of culturally competent physicians who can provide medical care and prevention services that are specific to the LGBTQ community, an area that's long needed specific attention. The term culturally competent is so important to us. It fits right in with our statement on professionalism, really our North Star. We chose to modify the terminology from cultural competence to cultural humility in our statement, but the aspiration remains the same. Our statement commits us to rely on cultural humility, kindness, and respect in all we do. Patients and their families have enough on their plates dealing with disease or a condition that brought them to our clinics or our hospitals. Once there, they should never have to struggle to find respect and understanding from their healthcare providers. So on behalf of a grateful Larner College of Medicine, I thank Dr. Imbasciani, a practicing urologic surgeon who's taken time from his busy role in addition as Secretary of the California Department of Veterans Affairs to be with us here today. We also thank George DiSalvo, in his absence, for the important role they've had in terms of providing this lecture, and for George's role in healthcare as a leader of the Kaiser Foundation Health Plan. Now today we get to hear from Willy Wilkinson, an award-winning author, cultural competency trainer, and longtime advocate for marginalized populations. He's worked for years on the front lines for the advancement of health equity and for the LGBTQ community. And I'm really eager to hear his thoughts and ideas today as he talks about advancing trans-affirming care. But first, to tell you a little bit more about Willy Wilkinson, it's my pleasure to introduce Associate Dean for Diversity and Inclusion, Dr. Margaret Tando.
Thank you, Rick, and thank you all for being here. I'm going to stick the script today. I'm Margaret Tanda. I'm the Associate Dean for Diversity and Inclusion. And like Dean Pate said, we would like to thank Dr. Imbasciani and George DiSalvo who in 2015 generously funded this series. This is our 5th lecture series, and I think we are definitely in for a treat and for an education today. This year we were able to form a selection committee to choose our speaker, and I would like to welcome Dr. Michael Upton, who will introduce Willy to to us. So thank you again for being here. And Michael.
Thank you, Margaret. Thank you, Dean Page. Thank you, Vito. Welcome, everybody. I do think you're in for a treat. So get ready, because I think we're going to be educated and maybe have a little bit of fun today. Willy Wilkinson, MPH, is an award-winning writer, public health consultant, cultural competency trainer, public speaker, and spoken word performer. He is the author of Lambda Literary Award-winning book, Born on the Edge of Race and Gender, A Voice for Cultural Competency, which illuminates the trans experience from a Chinese American and mixed heritage perspective and transforms the memoir genre into a cultural competency tool. Willy was the first Asian and first transgender community health outreach worker providing street-based HIV education and crisis intervention for sex workers and drug workers in San Francisco. He was the lead consultant at the California statewide Community Alliance for Culturally and Linguistically Appropriate Services, where he conducted a high volume of LGBT and trans-specific cultural competency training and technical assistance. Willy has provided LGBTQ and trans-specific training and technical assistance for hundreds of community health organizations, educational institutions, and businesses. He is the recipient of the National Lesbian and Gay Journalists Association Award and the Transgender Law Center Vanguard Award, and is recognized on the Trans 100 list. Willy earned a master's in public health and community health education at UC Berkeley and a BA in women's studies from UC Santa Cruz. He lives in Oakland, California with his 3 vibrant young children. Please help me welcome our 2019 Imbasciani speaker, Willy Wilkinson.
Thank you so much. Can you hear me? All right. Just put a little volume on that. Can you hear me okay? Is that too loud or is that good? Okay. A little too loud? Oh, sorry. Okay. Is that good? All right. Thank you so much for the introductions, and thank you so much for the invitation today. I'm really honored to be here. Thank you to the selection committee who decided this, so I really appreciate it. And I'm thrilled to be here as an out trans person and a long-term cultural competency trainer on LGBTQ issues with a focus on trans issues, to be here and talk about this issue today. Is that good in terms of, are we getting reverb? Are we getting reverb? Sorry, maybe I turned that up a little bit too much. Are we good? Are we good in terms of volume now? Okay, I don't want to blast your eardrums. So yeah, I mean, you know, anyway, it's an honor to be here, and thank you. It's really great to hear about the amazing work that you're doing at this College of Medicine on LGBTQ issues. And, you know, let's continue that conversation. But first I want to ask you, you know, how many people here are students? Okay, great. And how many people here are faculty? And how about staff and community health providers in the community? All right, great. Great to see you all here. And thank you so much for taking the time to be here today. So let's talk. Let's talk about what trans experience is. Let's talk about what the cultural competency issues are and what are important considerations in providing trans-affirming care. And I know that many of you may have a background on who trans folks are, but I just want to start out so we're all on the same page on who trans people are, and then we'll move on from there. But you're familiar with this term, sex assigned at birth? Yes, okay. So quick read of the delivering, from the delivering provider. Dun, 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 dun. Here we have a boy or a girl when people do the gender reveal parties and all of that, right? But that's sex assigned at birth. Gender identities, how we feel on a soul level in terms of our gender, right? Are you male? Are you female? Do you feel your gender is something other than male or female? And, you know, of course, gender identity is distinct and separate from sexual orientation. You think about your own sense of gender and who you're attracted to. Those are two different things, right? So we got that. So let's talk about pansexual. What does that mean? That means attract people who might be attracted to folks that's in a way that's not limited to particular gender identity or sexual orientation. And I'll circle back to that, why I'm bringing that up now. But, you know, when we talk about trans folks, we're talking about people who have a gender identity that's different from the sex assigned at birth. Are you familiar with the idea of the binary gender system? Yes, okay, great. So the idea that there's only two ways to be, right? Male or female, and a bunch of expectations that come with that, and a growing community of folks who are identifying as non-binary, right? As saying that male or female is not exactly accurate for them in terms of their identity. Also the terms gender expansive, are you familiar with this one? Gender expansive? You know, people often use the term gender nonconforming, but you know, I think it's helpful to think about that. That's a very culturally based term. What might be considered gender nonconforming in one cultural framework may not be in another. And so there's an organization that supports young people and their families called Gender Spectrum. They use the term gender expansive rather than gender nonconforming because they interpret gender nonconforming as judgmental. So gender expansive is talking about, you know, people who might be expanding the ideas of gender. So for instance, the little boy wants to be a princess for Halloween. People say, oh, what does that mean? How does he identify? Well, maybe he just wants to be a princess for Halloween, you know? And, you know, but people might say, okay, that's gender expansive, right? So anyway, helpful to keep in mind some of this language as gender expansive. Right? And I think, you know, when we talk about these different concepts, you know, non-binary identity, some people identify as trans and non-binary, some people identify as non-binary and not identifying as trans. So recognizing these distinctions, some people want to change their bodies to fit how they identify in their mind, and other people are not interested in changing their bodies medically. So just, you know, keeping that in mind. Also transmasculine, transfeminine, folks familiar with these terms? Okay, so, you know, for instance, describing people on a spectrum of identity. So transmasculine assigned female at birth, people might identify as male, not everybody identifies as male, recognizing that spectrum. And then also transfeminine, folks assigned male at birth. People might identify as female, but not everybody identifies as female. So helpful to keep in mind as you discuss these issues and recognizing these different words. No, these are not all the words to know, but words currently that are helpful in understanding these issues. An older term, transsexual, you know, generally used to describe people who have accessed some form of medical intervention living 24/7 in a gender that's different from the sex assigned at birth. And the term cisgender, familiar with this term, folks? Okay, so you're identified with your birth sex. So for instance, assigned female at birth and identifying as female. And you know, organic chemistry was a class that I did not do as well in as others, let's just say, but that's where the molecule comes from, cis showing it's the same side, trans across, and that's the idea. Because in the past, people would say, a trans woman and a real woman walked into the room. Now, what's wrong with that? Tell me, what's wrong with that? Okay, trans women are real women, right? Okay, right? So, you know, people would say, or a trans person and a biological, you know, it's like, wait a minute, how do we describe folks in a way that doesn't say one experience is better or more authentic than the other? And so that's where that term cis or non-trans you might hear as well, where those terms come from. It's distinguishing these experiences. What about the word tranny? How do you hear that being used? Positive, negative, what are your thoughts? Yeah, I mean, it's interesting, historically was used in a very positive way as a term of pride. Like in the 90s in San Francisco, we had venues, organizations, people very much embrace this term as, you know, we're fierce, we're badass, we're creative, we're different, it's cool, right? Over time, it's been very much used in association with hate violence. And at this point, people really do not want to hear it. So let's just say on that one, just recognizing that's a word to exercise caution around. So I'm gonna ask you this. What's the difference between non-binary and pansexual? Okay, right, you guys got this. All right, good, we're on it. Moving on. But understanding these are complex identities. Non-binary doesn't say anything about who the person's attracted to. Pansexual doesn't say anything about how one identifies their gender, okay? And pansexual is recognizing there might be more than two genders, right? So, and if this makes your head spin, you know, feel free to ask me questions after, but we're going to move on. But I want to also talk about a book that came out not that long ago in January, and this was written by S.J. Langer, who's a trans psychotherapist in New York City, theorizing transgender identity for clinical practice. Draws from psychoanalysis, philosophy, neuroscience, and trauma therapy to offer a new model for understanding gender. And what he's discussing is, you know, what we might consider a no-brainer, but I think is really important to understand, that trans identity, experience, and expression is a variation in human gendered existence rather than pathology. So much of the literature still positions cis people, cisgender people as the norm and pathologizes trans people. So recognizing this is a normal part of human diversity, and also he makes the point that gender is an interactional process across mental and physical systems. So it's not just in the body, it's not just how we view the body, it's all of these things interacting. That gender is core and inseparable from consciousness, more than the body image and the visual realm. It involves all sensory input. So it's not just the image in the mirror, it's how we feel in the body. And he talks about the free energy principle, that the body is perceived through predictive coding, a certain expectation that our bodies are going to be a certain way, that the brain has a non-conscious prediction, this prior belief, and then that what the prior does not match the stimulus, there's a surprise, a disequilibrium. And so this idea, now this may not apply to all trans people, but the idea that there's a sense of how the body should be, and this sense of surprise and the disequilibrium, that most cisgender people are not aware of how they know their gender in the way that you don't necessarily think about your heartbeat. It's just there, right? That most cis people don't have to feel their gender, but trans people are experiencing this gender dissonance as free energy. You follow me? So now he talks about, as a psychotherapist, and how he can help people really try to bridge that. And he talks about experimentation with clothing and prosthetics, and how that can feel really electric for folks. But then there's also this piece of internalized transphobia and shame, being told all our lives that we're not okay, that we're wrong, that it's not okay to be who we are. So also other ways, non-gendered physical activities, such as dancing, yoga, sports, and how that can also be a way to embody one's gender in a way that's not necessarily requiring people to be gendered in any particular way. And for people who pursue medical transition, for whom that is really right for them, there can be this sense of gender equilibrium. So I wanted to share a quote from Talmadge Page McBee's award-winning memoir, Man Alive. "I didn't expect the visceral pleasure, either the joy I found laying a hand on my rising pecs or lifting my shirt to study the hard center of my abs. I didn't expect the shift in my center of gravity or the calf muscles so big they brushed against my pants. I didn't expect the calm at the core of me, my strength a tactile feeling, cool and placid as a lake." And so I think he very beautifully describes that sense of calm, a sense of the body being returned to the proper form for people who are interested in medical transition. And not everyone is, but for people who are, that can be so incredibly powerful. So I want to ask you this, and I know that you talk about cultural competency, you talk about cultural humility, and recognizing there are different ways or different terms that people might use. Cultural humility, cultural responsiveness, cultural agility. What does it mean to you, cultural competency? And how do you talk about it in your work? What does it mean? Anyone? What does cultural competency mean to you? Okay, thank you. Anyone want to build on that? What does cultural competency mean to you? Okay, working across differences, cultural experiences. Other thoughts?
Competency implies that there's an endpoint and you reach the mastery.
Right. Oh, I took that 2-hour class. I know all about it, right? What? No, we're talking about a journey, not necessarily a destination, right? This is a process of lifelong engagement. There's not necessarily an endpoint. I write about cultural competency in my book, and this is how I describe it. Cultural competency refers to the ability to understand, communicate with, and effectively interact with diverse populations, and can be measured by awareness, attitude, knowledge, skills, behaviors, policies, procedures, and organizational systems. So I think we are really talking about navigating the interactions appropriately, but also setting up affirming systems. I think that's critically important as well. And how do we learn about a population while treating everyone as an individual? It's fundamentally about holding another human being's cultural framework as authentic to them and accepting their perspective without question, judgment, or revision. How do we manage bias? How do we recognize bias? And how do we manage bias? So I think those are questions to think about. And, you know, are you familiar with the class standards? Nationally standards on culturally and linguistically appropriate services. Are folks familiar with this? Now, this was developed in the year 2000 through the Office of Minority Health, specifically looking at race and ethnicity in healthcare settings, which is critically important. How do people, you know, recognizing people's cultural beliefs, you know, making sure that people can access care in their appropriate language and so forth. In the year 2013, they updated the standards to recognize not just race and ethnicity, which is also, was very important, but also a total of 25 cultural groups, including sexual orientation and gender identity for the first time. So it's a series of guidelines, and they also recognized not just specifically healthcare settings, but anyone who works in community health, broadly defined, as well as educational institutions. And my feeling is really all spheres of society could benefit from this framework of looking at, you know, these issues and what that means systemically in providing culturally competent care. And so one of the critical pieces, and I know that you're talking about this on your campus and so forth, is this piece around name and pronoun, right? And the correct naming, the name the person goes by, which might not necessarily be reflected on their medical record or their ID, the pronouns that people use, you know, and so forth. You know, and I know that you may be working with folks who use they, them pronouns. And I know that many times people are still struggling with using they, them, theirs as pronouns. But, you know, I don't know why it took us so long to figure this out. In the past, we used to make up pronouns like ZE and different pronouns, you know, but this is actually part of the English language. It's not that hard, you know. It's really like we talk about people in plural form. It's just about adjusting to talking about one person. But when you think about it, we use it all the time. You know, somebody says, oh, this company called, and the other person says, oh, what did they say? You know, it's a gender indeterminate pronoun that we use. And, you know, some people say, oh, it's not grammatically correct. Guess what? The grammar people have gotten over it. You know, they're like word of the year, you know. So it's really, you know, so this is just one of those things that's really, really helpful to exercise. So, as someone said in a training I did the other day, it's a muscle I need to exercise. And yes, and I think it is about getting fluent with this piece. I also want to draw your attention to this idea of this idea of preferred pronoun. There's a growing movement away from that language. Why do you think that is? It's not preferred, right? So I think it's interesting, and I've always thought this was incredibly subjugating, even though this language came out of the trans movement since like the 90s. You know, it's really, it's interesting that cisgender people's pronouns are intrinsic and true, but trans people's pronouns are viewed as preferred, when in actuality, they are intrinsic and true. They are who we are, yeah, thank you. And so I think there's a growing movement away from that. So we don't necessarily have to qualify pronouns as being preferred. We can just talk about gender pronouns or pronouns, right? And what do you do when you're not sure what pronouns or gender terms are appropriate? And what do you say? What pronouns do you use, right? And yeah, be careful, ask for what you want. If you ask how you identify, you're not necessarily going to get that information, right? So, I mean, I think there's no perfect handbook on this. You know, I mean, people might have that information, you know, listed in their email signature, depending on, it might be listed in their chart if you're working with patients and clients. But, you know, I think one way that can be very helpful is to say, you know, hi, my name is Willie, and I use male pronouns. Hi, my name is Willie, and I use he, him pronouns as a way of leveling that playing field in a way to talk about it. Not just like, oh, you're different, I'm going to ask you, but I'm going to introduce myself, and this is how we can introduce and so forth. So, you know, I mean, and I know this is probably something you're doing all the time on campus, but I think it bears mentioning because, you know, this is something that continues and continues and continues in the medical field, this issue of pronoun use. Other ways, you know, depending on the situation, you can be gender neutral. You know, depending, you know, if you're referring to somebody in a pinch, you know, I think sometimes we'll use the pronoun they, but recognizing that that may not be the appropriate pronoun. It depends on the situation. If any sort of long-term engagement, we really do want to identify that. But the critical piece to understand here is the impact of being misgendered. And being misgendered is being referred to with the wrong pronouns or gendered language. It's something that is an ongoing stressor for folks. It's something that people may have been experiencing for years with their family, their community, their school, their workplace. It can make people mad. It can make people sad. It can make people say, well, you know, that provider, that clinic, that whole institution does not honor me, does not see me. I'm not going back for care and services. And that can really contribute to negative health outcomes because people get turned away from services because they feel they're not really being respected. It impacts people on emotional, psychic, even physical level. And I want to share a story that I haven't told that many people about, actually, but why not tell all 300 of you and the internet, because it's relevant. Last December, I was in Palm Springs on business. I was there to present my workshop on creating trans-affirming schools at the California Teachers Association, which I've done for the last 4 or 5 years. And I woke up that morning feeling not so well. I felt fatigued. I felt woozy. But I had this workshop to do, this 2-hour workshop to do in the morning. So I did it. I, delivered an engaging, informative workshop, but I noticed the last half hour I was feeling kind of shaky and cold. And a bunch of people wanted to shake my hand. At the end, I realized my hand was just icy cold. So I went back to my hotel room. I had to check out. I couldn't lay down for long. And I thought, okay, I'm low blood sugar. I better get some food. So I tried to get, drive. It was challenging. I had to walk half a block. It was challenging. I went to get some food. Finally, I sat in the parking lot. I was thinking I was going to drive an hour and a half to the airport. And I realized something's not right. And by the time I called 911, I could not use my arms. I had no idea what was happening, and my phone was dying. And, I couldn't actually state my location. I told them I was somewhere else. They said, we went there, you're not there. And I could not look up my location, so I gave them landmarks. I said, oh, there's a yellow liquor store. There's a liquor sign above. There's a rainbow-colored alcohol ad. Oh, I'm at a liquor store. Well, it turns out I was across the street from the hospital. They found me in the parking lot, confused, and they immediately misgendered me from the moment they came to save my life, because I did not realize I had a temperature of 104.7. I had sepsis, which is the third leading cause of death in the US, and yet most Americans don't really even know that. I did not know that. So I was glad they were saving my life, but at the same time, during a medical crisis, I had to deal with being misgendered. And because I was confused, they insisted they knew better than I did what my pronouns were and what my gender was. I was experiencing the mental confusion of sepsis. I think, and then I went on to have a week of hospitalization in Southern California and then in Northern California. And during that time, I was misgendered repeatedly. And when you're in the hospital, nothing but a gown and an IV, that's not a healing environment, to be misgendered repeatedly. The thing about it was that when I talked about, this is not a healing environment, I need you to understand, these are not my pronouns, it was hard to really get the apology that I wanted from the folks who were doing the actual misgendering. People said, they made excuses. They said it was not their responsibility. They went on and on about how they get people's names wrong, or they laughed it off. They laughed off the disrespect as if it was all a big joke. But I did also want to say I had very positive experiences with nurse leaders and management, and we did really have these good conversations, and people were I did have very positive experiences as well. But I did continue to experience this impact of being misgendered. And so I think, when we talk about misgendering, it's important to really look at how do we recover gracefully? Because when you realize you blew it, what do? Do you say, I didn't know, I thought you were a man or a woman? Would you say that? Why not? Okay, why would you not say this? So Dr. Tando is saying, okay, you're leaving out a group of people. Why else would you not say this? You're blaming the person for the mistake, right? Is it about your perception or is it about the person's identity, right? So we say, no, let's not do that. Okay, how about this one? This is silly, I get everyone's name wrong. Oh, no, I heard that one. No, let's not do that. How about this? I'm sorry I misgendered you. I didn't mean to disrespect you. Okay, right? So they're, short and sweet. Doesn't need to be a lengthy story or anything like that. It's really, I think what we're doing here is we're talking about acknowledging and repairing the harm, recognizing that that was a moment of harm. Now, I was doing a training with some educators, and the person said, well, is it harm if I didn't mean it? Well, I think there's a difference between intention and impact, right? And so helpful to keep that in mind as well. So, but it's like when we talk about medical harm, do no harm, right? So much is often focused on medical access, and that is, of course, incredibly important, but less focuses on the emotional and psychic harm. And so I think this is what we're talking about when we talk about the experience of being misgendered in healthcare settings. And yet this is really just the tip of medical harm that trans people experience. And I'll come back to that. I also want to talk about nonverbal communication. A lot of times, people get looked up and down disdainfully, and a lot of times that is unconscious. And so that's helpful to keep in mind as well. When we talk about, what does it mean to really honor and respect folks? It's about, recognizing the authenticity and validity of gender identities, one's gender identity. Regardless of what people look like, regardless of their hormonal or surgical status, regardless if they've legally changed their name and gender, and recognizing that people do have the legal right to access services in accordance with their gender identity. So, I want to talk about this piece around transition and, really what it looks like in terms of healthcare access. Important to understand too that not all trans people are interested in medical transition. Some people are interested in social transition, which is really changes to name, pronoun, gendered language, appearance. That may be all people are interested in. But when we talk about medical transition, that can include mental health care, hormones, puberty blockers for young people, surgeries, and other gender-affirming procedures. And it really varies depending on the person's preferences, their healthcare status, their finances, their ability to take time off work, perhaps in order to access surgeries and recover from surgeries. I think what's also critically important to understand is this is medically necessary care. The American Medical Association and American Psychological Association and so on and so forth, many other entities have long since recognized that this is medically necessary care. It is not cosmetic or experimental, as it's often portrayed by opposition. And there's no one way to transition. There's so many ways that people might pursue or not pursue transition. But it really can be life-saving when we talk about the high suicidality in trans communities. There's a direct correlation between suicidality and a lack of access to culturally competent care. So here's a quote. I have struggled with anxiety and depression ever since puberty. I failed classes, isolated myself, and considered suicide because of this. A year ago, I felt hopeless and had daily suicidal thoughts. And today, I've got a plan for the future and haven't had a serious suicidal thought in months. I firmly believe this is because of my transition. I feel so much more comfortable and happy than I've ever been. And in California, where we have had health insurance coverage for transition-related care, including surgeries, in the last 5 years, I have personally witnessed how this has transformed the mental health status of people in my trans communities around being able to access transition-related care, including surgeries. But historically, and this continues to be the case in certain states, that there are historically transgender exclusions in health insurance. Now, first of all, trans people not getting denied a policy at all, simply for being trans. And this is why the Affordable Care Act is so helpful, because being trans is considered a pre-existing condition. Also, Section 1557 of the Affordable Care Act really deals with sex discrimination and protections for LGBTQ folks. But a lot of times people have been specifically excluded from even getting a policy simply for being trans, and then insurers have they have a rider in their policy saying specifically they do not cover trans care and services, which means no coverage for gender transition, but can also mean no coverage for sex-specific care. So for instance, a trans man unable to get coverage for gynecological care, or a trans woman not being able to get coverage for prostate screening. And so the insurer will say, oh, ding, men don't have uteruses, we can't cover that, right? And then, especially egregious, no coverage for any service considered related to being trans. So the policy says we don't cover transgender care and services. Too bad you have a liver issue, you're on hormones. We don't cover trans care, so we can't cover the liver issue. Too bad you broke your arm. That affected your bone health, your hormones affected your bone health. And so since we don't cover trans care, we can't cover your broken arm. That's called the trans broken arm syndrome. You know, the thing that trans people can't even just get basic primary care simply for being trans. Now, in the last 5 years, we've seen some great changes in health insurance coverage, but only currently 20 states and the District of Columbia prohibit trans exclusions, including Vermont. That's great. You know, but we're talking about HMOs, PPOs, and Medicaid now providing transition-related surgeries covered by insurance, which is transforming you know, those communities that are those states where people are actually able to get health insurance coverage. But now we have these disparities between states where people can get access and can get their surgeries covered versus people who are in other states and unable to get coverage. And so that's really, the landscape has changed so much in that there's such incredible disparities. But historically, people were saving for their lifetime, hoping they might be able to afford getting transition-related surgeries. And in some states, that has changed. You know, so important points to remember, you know, gender identity, you know, right? It's what's between the ears, right? Not necessarily what's between the legs. It's really how we identify, right? There's many ways to be trans and non-binary, as there are people who identify these ways. And some folks are interested in changing their bodies, but not everyone is. So I want to also talk about, you know, the health disparities and what that looks like. And, you know, trans people have been discriminated against in every sphere of society, you know, in education. 78%, 3/4 of people report having been bullied in their K through 12 experience. This was from a large scale study of 6,456 participants in every state and territory of the US. On the issue of employment, 47% of trans people have been fired, not hired, or denied a promotion simply for being trans. You know, on housing, you know, of the 2.5 million homeless youth in the US, 40% are LGBTQ identified. Many of those folks are trans, non-binary, gender expansive folks. You know, and then, you know, we'll talk a little bit about the lack of family support too in a minute. But I think, you know, when we talk about, you know, why are we seeing trans folks presenting with substance use disorders? Why is there high suicidality? Why might people be experiencing risky sexual behaviors? To be affirmed in one's identity, or maybe to get a place to crash because people are struggling to survive. You know, people are presenting with different issues based on, because of the experience, not because people are inherently wired this way, but because of the experience of discrimination from all spheres of society. You know, the hate violence, you know, that people are experiencing, especially trans women of color, especially Black trans women. And, you know, it's just something that is so constant that people are feeling, you know, that it's just a challenge to walk down the street because of the level of harassment people are experiencing. This is Victoria Arellano, who was in ICE custody, and as an HIV positive individual was denied her medication and died in ICE custody because she was denied her medication, her HIV meds. You know, this is when we talk about the type of medical harm that trans people have experienced, you know, people have experienced so much harm in terms of denial of care. And, you know, here, there are many, many stories to tell, but this is Gwen Araujo, who at age 17, who was from Newark, California, in the Bay Area, at age 17 died because of hate violence, because she was associated with guys who, once they discovered that she was trans, murdered her. And because in that case, you know, there was the gay panic or the trans panic defense that people would say, I panicked, I can't be gay, I had to murder this person. And that actually was a defense that people used to make the victim responsible for their own murder. But with that case, we changed that in the state of California, that is no longer a defense that can be allowable. These are some of the young people we've lost to suicide. Ronan Shimizu was bullied from the time he was in kindergarten, joined the cheer squad in 4th grade. The girls accepted him, but constantly bullied, his food taken, knocked out of his tray in the cafeteria, his shoes taken from him, his face slammed into the sink in the bathroom, told he didn't belong in the boys' bathroom. We don't know how he identified, but he loved being a cheerleader. But by the time he was in 6th grade, he was homeschooled because he had such PTSD from going to school. The school was not demonstrating leadership. They were disciplining him as well and not recognizing what was going on with the bullying. He died by suicide at age 12 in 7th grade. That is a preventable death. It was only after the lawsuit that the Folsom School District then decided to do an anti-bullying campaign. But these are the kinds of things that are happening constantly. And here's Monica Jones, who, as a student in Phoenix, Arizona, accepted a ride from undercover cops and was charged with, quote, manifesting prostitution because of the presumption of criminality of her as a Black trans woman. She just needed a ride. So she's really spoken out about her case. Juan Evans, being, when he was pulled over and his gender presentation didn't match the gender listed on his ID, called a bunch of nasty names and threatened with being strip searched on the side of the road. So the kind of dehumanization that people are experiencing. I think when we talk about, what is happening for folks and how does this affect our bodies as we seek healthcare? People are experiencing these impacts on a daily level. We talk about the issue of family acceptance. Now, this was from a large-scale study of almost 28,000 people in every state and territory of the US, trans adults, on the issue of family acceptance. So the darker color line is showing people who identify as having supportive families, and the lighter color line is showing people who have identified as having unsupportive families. And you can see on the issue of homelessness, attempted suicide, and currently experiencing serious psychological distress. So you see how the impact of a lack of family acceptance, but how that really impacts people, but also that's not the whole story, that family acceptance isn't everything. Again, what's happening for folks in their K through 12 education experience. And you look at this. This was that study of 6,456 respondents, every state and territory of the US, that you see these high incidents of harassment, physical assault, and even 12% experiencing sexual violence in their K through 12 experience. So, when we talk about, well, what are the barriers to access? That people might be kicked out of their home because of their trans status, which can limit folks' education. People might move to a major city to be themselves, but the struggle to survive, the high cost of living, and the difficulty accessing employment, housing, healthcare can lead people to potentially risky behaviors. And recognizing, of course, that people of color are systematically discriminated against in multiple ways, as well as people with disabilities, and recognizing those intersections. On the issue of restroom access, I was great to see some of the all gender restrooms that you have on campus. I think, a lot of times people, when they talk about the restroom issue, it's always about this fear, the non-trans experience, but rarely do we hear what that experience is like for trans folks. And this is not something that just trans people experience, so broader LGBTQ community experiences these issues as well. This again was this large scale study with almost 28,000 respondents. And so these are people in every stage of life and every stage of transition. And they asked people about their past year experience. 59% had avoided the restroom out of fear of confrontation. That 1/3 had limited their food and liquid intake so they wouldn't have to go. But especially, look at this, 8% had a negative health outcome, a UTI, kidney infection, or other kidney problem as a result of avoiding restrooms. And that's the very real negative health outcome of a lack of restroom access. So if you're wondering why we have all gender restrooms on campus, this is what it's about. If people are holding it all day long when they go to school or work, that's not a positive thing for folks. So let's talk about the harm perpetuated against trans people. Emotional, psychic, physical, sexual, and it happens in racist, transphobic, ableist, classist ways. And it's rooted in this idea that trans people aren't full human beings, hatred, bias, dehumanization. And, I think when we talk about harm, it's very much literally directed against our trans bodies. It questions, assesses, and makes pronouncements about our very humanity. And it's especially destabilizing to our bodily autonomy and sense of safety. And a constant reminder that many people don't see us as full human beings. And the thing about it is that harm is often inflicted by people who have had the immense privilege of having access to our intimate bodies as lovers, family members, and as healthcare providers. And so, medical harm comes often in the direct experience of a lack of access to care and coverage. So for instance, are you familiar with the story of Tyra Hunter? This is a really important case in history to know about. This was 1995. Tyra Hunter was a very popular hairdresser, 24 years old, in Washington, D.C., who died after a car accident when paramedics, firefighters, once they discovered that she was trans, they called her racist and transphobic epithets and laughed at her trans status while 5 to 7 critical minutes passed. And people, the bystanders, were encouraging them to continue saving her life. Finally, she was transported to DC General, where an ER doctor refused to take care of her, refused to save her life. At the trial, experts testified that had she received care at either stage, she had an 86% chance of survival. So this is the very real impact of medical harm. So this is a historical case, and yet these things continue to happen. This is a current case, Evan Minton, who the court have just ruled that he can pursue his case against Dignity Health. Now this is in Carmichael, California, which is near Sacramento. Once they discovered he was trans, they canceled his hysterectomy. And they said that he would never receive a hysterectomy because he was trans, that Dignity Health would never allow that. And so that case is now proceeding to trial through the ACLU. I want to speak to that piece of harm. I also want to speak to, what are the ways that we can really, create affirming systems and provide affirming care. I think it's really timely to talk about SOGI data collection. Are you familiar with this? SOGI, sexual orientation, gender identity, S-O-G-I. That's where SOGI comes from. SOGI data collection. There are local, state, and federal requirements now requiring that healthcare institutions collect data on sexual orientation and gender identity. Now, it's not like, oh, you look queer, I'm gonna ask you. It's like everyone is asked and response is 100% voluntary. Anyone can decline to state. The information is protected health information. Now, I work with a lot of nursing students and nursing schools, and I keep hearing, oh, is being trans protected health information? Yes, it is protected health information that can be shared within the health network, but important to recognize this is not something that is being individually reported, because people are like, what? Why do you want this information? They're gonna round us up? What's going on? It's really about showing the trends and who is being seen. And yet we don't have consistent protocol. We know the questions we wanna ask, but the options for response are all different. Every healthcare institution has a different way of approaching this. And I've worked with a number of county health departments and large healthcare institutions. Everyone is grappling with this. And the question is implementation. Do we hand people a form? Do we ask it verbally? In one clinic, I was working with, they were doing it on a grease pad. So people were putting the responses on with a grease pen. And then that was handed to the person at the front desk, where it would sit to whatever to somebody to input it, right? So what is the implementation? Where is the data going? Who's seeing it? And how is that happening? In one clinic, people said, well, we're not getting as much data there. And it turns out the staff was, well, we didn't feel comfortable asking the questions. So we really have to work on how can we help patients, how can we get staff get up to speed? And how can we also explain it to patients and clients about why this is important? The other piece is electronic health record systems. If we get the person's chosen name, the name they go by, does it populate when we go to call them in the waiting room? Or are they still getting called by the billing name? If we ask them their pronouns, is that populating in a way on the electronic health record so that that can be visible when people are working with folks? This is why we collect SOGI data. We want to know who we're serving. We want to know the trends. We want to know what the training needs are, the health disparities. We want to know, about screenings, assessments, and so far. We want to, target marketing materials. And it's really about providing relevant, specific, compassionate care. Of course, people are uncomfortable. They say, oh, I can't ask that older, I can't ask the older Chinese guy. I can't ask, somebody who's older, or somebody's from a traditional culture. Maybe that 60-year-old Chinese guy has been waiting all these years for you to ask them. It's really, we can't make those assumptions, right? So, people have discomfort, like, oh, they're going to ask me a question I don't know how to respond to. Oh, it's taking too much time away from patient care. Guess what? This is patient care. So, so those are the kind of concerns, and then of course, patients and clients being worried about, who's getting this information, or, just being uncomfortable with being asked questions that feel intimate. I think it's a demographic question. In the past, people said, well, why are you asking me about my race? Now that feels much more standard. Maybe in 10 years, we'll say, oh, this is standard, but this comes with particular challenges. I've worked with institutions to create a train the trainer curriculum and provide trainings to help then large scale institutions be able to then train their employees. And so what's been helpful is developing leaders and champions on this. Sometimes working with trainers, there's people who have experience that they have expertise in content, or they might have expertise in training, but not necessarily both. And so helping bridge those gaps, helping people feel ready to respond to whatever challenges might come up, and also giving people resources so they have written materials that they can hand to folks if they have questions, that there are resources to turn to when people have questions and are navigating system challenges. And particularly for members of the LGBTQ community, questions come up. Should I disclose my identity? How do I need to take care of myself in doing this work? So, but I mean, best practice is really looking at, how can we provide training? How can we build awareness around this? How can we develop skills to ask these questions appropriately? And how can we respond to the questions that come up and any other concerns that come up? So I want to move, I know I'm running out of time. I do want to talk about what does it mean to be an ally? And when we open it up, I want to hear from you, your thoughts on this with the community you serve, with your colleagues. Of course, we want to educate ourselves in ways that don't put a burden on trans people. What is the work that we can do to educate ourselves on our own? And if we're confused about when we are, working with folks, what questions should we ask that are appropriate to care? Working through biases and misconceptions, and what does it really take to foster a healing partnership with trans patients? Recognizing that power dynamic. Anyone can be an ally. That's the beauty of allyship. I think, also maintaining confidentiality is so critically important. I think a lot of times people don't realize just how critically important that is with trans status. I mean, just as a quick example, I have a friend who was having a mental health crisis and went to a residential mental health care facility, and a psychiatrist outed his trans status to other clients in a residential facility. That made him feel very unsafe. These kinds of things happen where people make casual conversations about this, so critically important. Of course, being consistent, also consistency critically important in creating a non-discriminatory environment. And then keeping questions relevant to care and services. I went into the ER a few years back with intense nausea, which turned out to be a bad flu. And the doctor asked me about my genital status. And my response was, is that relevant to care? Because I'm there for nausea. Are my genitals really important in that moment? So really, I think if you're asking questions, it's always helpful to say, I'm asking this question because it might just look like you're asking out of curiosity and indulging in curiosity, right? And so as we support our LGBTQ patients and colleagues, and I mean the people that you're going to school with or the people that you're working with, how can we refrain from assuming the certain intimacy? Like, oh, I know you, I can ask you about your genitals, right? It's like, would you ask everyone that? So like, and also like, how can we be advocates? How can we also address LGBT issues if we're not LGBTQ? So that LGBTQ aren't always responsible for addressing these issues. And it's important also to recognize microaggressions as they occur. So I want to come back to this piece around, as we open it up again, looking at, well, what can we do to increase access to affirming care for trans, non-binary, and gender expansive people? But I want to leave you with this, and just, I want to say that, that the racist, transphobic, psychic and physical violence that so many of us experience in the form of demeaning, dehumanizing messages about our bodies, literally, and our body parts. It doesn't just wipe off. It becomes integrated into, into our being, really, on a cellular level, because I think the living, breathing cells have to wall it off with scar tissue. And they're not, scars aren't something that can be extracted, really, without harming the healthy tissue. So we learn to live with them. And so remember, as you work with trans people, that you can't necessarily see all the scars that they have, or even the harassment they dealt with on the way in to see you. For me, as a trans person who for the first 3 decades of my life did it on my own, I changed my name to Willy when I was 9, at a time when there was no dialogue, no conversation, without really the family, community, or systemic or school support, or even peers, or even language to describe my experience. I've survived somehow, because I have found a way to transform pain into creative and physical expression, and disappointment into movement and action. And I now have a beautiful family with my girlfriend and 3 kids. And, I am a trans person who has built a life for myself. And people might see me as a trans elder. Yeah, I'm old like that, But, I realize the more that I work with young people, that people want to see that, we can get through these challenging experiences, we can build a life for ourselves. But, it's like, I'm still a trans person, I never stopped being trans, And so in my most basic humanity, I am doing the hard work of healing the harm that I have experienced in my body personally, so I can keep doing this work professionally, and to help you provide trans-affirming care that can heal the trans body, not just on an individual level, but on a community level as well. And so when it gets hard in med school, special shout out to the people of color here in Vermont, in recognition of the challenges that can come with demographic imbalance. And much love to the queer and trans and non-binary and all LGBTQ folks and people with disabilities. When the work feels hard, thank you for staying strong and keeping on and doing the work, because you are gifted with this amazing job, an incredible privilege, really. And so I think it's also important to remember that, yes, trans people have been harmed beyond your imagination. But remember this, trans people are some of the most resilient, resourceful, and truly magical people you will ever meet. And that resilience also lives in our bodies. So I want to end with this brief excerpt from a piece called The Poetry of Scars. Oh, it looks like we can't see that. Oh, the top there. The headings. Oh. The Poetry of Scars. Scars have written volumes that traverse my body. They speak in poetic whispers, creative tales, and journalistic essays. They have written their own memoir. Scars hold the glare of violent gaze, the harsh sting of words that can't be undone, the crisscross of fences closed tight and gates open wide. They have raged against a detached cleaver, bubbled into a boil, and healed into smooth dispassion. They are the crudely drawn lines of continual assessment, the snap and clench of disregard, the demarcation of access denied. Scars are the forced indentations of a legacy of punishment for the natural incongruence of our beauty. Scars contain the voluminous bloodshed of too many wars perpetuated against us under muted street lamps, in shadowy bedrooms, and in the blind of studio lights. They are the jagged, imperfect weave of this eternal loom of threat, the archetypal artifacts of our determination to survive. They are the collective tragic tapestries that recall the beloved and the lonely, reluctant soldiers who resisted and succumbed all too early. They arrive uninvited and unannounced, like house guests staking claim to a bare cupboard, creeping upon us insidiously before we can see their incessant stalking. Scars are the measured stretch marks of forgiveness and rebirth in motion, documenting the loosening and tightening of skin and the expansion of change. Sometimes our scars come with grandiose invitations and fundraising campaigns, complete with excited itineraries to a profound, uncertain destination, fearless and exhausted. They are the event goers, the fabulous ones, dressed to the nines in medical glue and silicone gel. They wear their pride in handsome body parts that have shifted in and out of existence, bearing the seam of two lives stitched as one. Scars are the starting lines and finish lines of marathons, the path to happy, and the road we thought would remain untraveled. Scars are the ink of our stories, the poetic tattoos of valiant warriors. Thank you. So I want to open it up for discussion. We have time, right? We have time to open it up. If you have questions, if you have comments, I want to hear your thoughts. Let's talk. Yes, go ahead.
I just have a quick question in terms of your advice regarding talking to pediatric patients who may identify as trans and how to address the regarding pronouns with parents in the room and how to be mindful of whether they would like to be considered out or not.
Yeah, I think that's an ongoing question for providers and educators and other youth service providers that work with young people. I think it's really important to be in communication with the young person privately and asking them what's right for them. Because many people might say, call me this, but don't do this in front of my parents. I'm not ready to, they don't support me, or I don't want to be out to them, or whatever the case may be. And so being sure that you're in communication with that young person about what they want. And there are certain situations where a provider is referring to an individual in one way, and the family member is then saying something else, and so they might be having the same conversation, calling the person by different names and pronouns. That might be the case, but it's also, I think it's just critically important to be talking to that young person about what they would want to see. They might want you to model that for the family, or they might want you to just avoid it altogether and use the name that the family wants them to be called, just because that's safer for them, and that doesn't, increase the stress in the experience. Other comments or questions?
May not be as accepting of different genders, how you can be an ally with patients to have them more accepting of other patients or medical students or physicians for that matter. So you mean in a situation where they might be interacting with folks? Where a patient may not be accepting. You mean like in a hospital setting, or in a what type of setting? In a hospital setting, for example. If you're witnessing mistreatment maybe by patients towards their caregivers. Yeah, and I know that it's one thing to have staff on board. It's another thing to really handle the challenges that come up with patients and clients in those settings. And I think it depends on the situation and what the setting is and what the interaction is. For instance, in hospital bed placement,
of course, you're placing people in accordance with their gender identity, and you're not asking anybody permission. I mean, I think there have been situations where medical providers have actually asked the other person for permission or whatever, but really it's not about asking somebody's permission, just as you would not ask permission for any member of a marginalized community in any way, so it's really, it's about, so for instance, in that type of situation, so for instance, someone says, well, why is this person rooming with me? Well, this person is here because they have every right, they're here for the same reasons, and they identify with, for instance, if it's a gendered, you're talking about a gendered situation. So if it's a gendered placement, for instance, this person identifies this way, this one, this, and this is why. And really, I think, it's you want to be able to educate in a way that doesn't violate the confidentiality of the individual or put them on the spot to explain themselves or explain the issue in any way. I think if somebody feels uncomfortable, then the person who's uncomfortable certainly has the right to move if there is the capacity, which there may not be. But that it's really about, moving the person with the issue, not the person who's the trans person, right? But if you're in a situation where you have a group setting, I do encourage people to do some sort of patient education around this issue. Again, not putting a trans person on the spot or asking them to do any of the education, really, or violating their confidentiality, but to really address these issues. And one way I've done this work with various different client populations is to start just talking about gender. Ideas about gender, stereotypes about gender, and the more people start talking about the ways they start to feel a little hemmed in by society's expectations around gender, a lot of people can relate to that idea. And so starting to think about gender in different ways and the expectations of gender and what that means. And that can be kind of an opening to, give people an opportunity to ask questions and to be able to address what their questions are and what their discomfort might be on that issue. But there isn't like a perfect handbook. Do you have a specific setting that you're thinking of where this is coming up?
If you might have a patient that might be not accepting either their caregiver, maybe being a transgender person or a different race, or any type of how to be an ally and what types of words you can use to not necessarily call out a microaggression, but to try to make the patient not feel as though they're being called out, in other words.
Yeah, okay.
I'll give an example, Willie. So I go into your room. I'm Dr. Tando. Hi, Mr. Wilkinson. I'm Dr. Tando. I'm your surgeon. And you say, oh, I thought you were the cleaning lady.
Mm.
How do I respond?
Wait, so you mean how do you respond? What do you mean? Wow. I mean, that's, so you mean you're asking how to respond in the situation where a microaggression is being directed at you?
I think that's Karen's question. Yes.
Yeah. But I mean, also, you mean like as an ally to the person who has just, like as a person who has witnessed that experience, you mean?
You are the person. I am the person that's experiencing.
But I think because it's like, I think it's really about when we witness those things, right?
Yeah, so like if I'm in the room at the same time, maybe I'm the medical student, she's teaching me in a clerkship,
right,
and I see this happen to her,
mm-hmm.
What is the best way to treat the patient in a way that, it may not be malicious,
right,
but it is something you say you want to call out microaggressions.
Right.
So how do you do that in a respectful way to the patient?
Yeah, I mean, I think those types of things which are just horrible, just horrible. I think it's really about as I think in a person in an ally role would say then this is Dr. Tandon who brings this expertise in this situation, and really just talking about the expertise of the individual. So, or for instance, if you have a trans medical provider where someone is like, making a disparaging comment about them or misgendering them, you're affirming what is right that and using the appropriate gendered pronouns or gendered language if they're being misgendered, and saying, so-and-so, and emphasizing the right pronouns for that person, and also emphasizing their role, their expertise, what they bring to the situation, because they're being discriminated against in a way that's, you know, saying, I don't see you, I don't recognize that expertise. And so as an ally, it's about affirming that expertise and about trying to change the narrative that they've decided in their mind about that individual. Does that help when you're talking about that situation? Yeah?
Yes, it does. I think one of the issues is how do we train our students
Yes.
to respond in that situation where they may be the only ones in the room with that patient, you know?
Where they're being treated in a way like, how old are you and what are you, and yeah, right? So yeah, so that's, I mean, I think, you know, again, it's about emphasizing the work to be done and the expertise that they bring and the role that they are in, right? You know, it's like, it's a challenge to be experiencing that kind of nastiness or those kinds of microaggressions that are very disconcerting and destabilizing. And so it's like being ready with that response of like, I am the doctor, I am here to provide, or whatever this, you know, I am here as a medical student, or whatever the role is, the title, and this is what I'm here to do. And, you know, I think, I mean, you know, I mean, a friend of mine just wrote this amazing poem. She went to a conference and she has a shirt that says psychologist, like it's 6 times across her shirt. You know, as an African-American, you know, a person said, really, you're a psychologist, you know, and just gave her this whole kind of, just kind of, you know, put her down and did not believe that was her profession. And so she wrote this amazing poem, like, I went to school this many years and had this many honors and did this, and I'm, you know, just kind of really talked about who she is and what she achieved, and this is who I am. And I think that's the thing that so many people are having to do constantly in those situations, is really having to say, this is who I am. This is what the expertise I bring. You see me as this, I am this. And so it's about, you know, being able to do that. But I think the important role of allies is recognizing that's a hard thing to do. It's very destabilizing in the moment when somebody has cut you down to be, I am strong, I am this. And so as an ally, I think it's a really, really helpful thing to be like, hey, you know, witnessing that is happening and trying to shift the dynamic and recognizing the expertise that that individual brings. Those are my ideas on that. I hope that answers your question on that. I mean, there's no perfect handbook on this, but it's such an important piece. Were there other hands? Yes, go ahead.
You talk a lot, very often parents should people are being denied access because of their healthcare provider or who they're. So how can we better advocate for patients to improve their lives?
Well, I mean, I think there are also great resources that there are people who are specifically advocating to help insurers cover some of the services that they have been especially denying. Some services are getting covered more than others, and some services have been more challenging to get coverage for, such as electrolysis or facial feminization surgeries. You know, those are the kinds of things. There are certainly some advocates that are doing that. And so I think it's really about getting connected to the advocates that are doing that work. You know, fortunately in this state, you remove transgender exclusions, but you may be working with people who have insurance in other states. And so understanding who are the LGBTQ rights groups and what are they doing around insurance advocacy, because every state has people in it who are doing this work to advocate with insurers. And so I would help them get connected to those resources, because recognizing, yes, you are trying to do your job as well, but helping folks get connected can go a long way. Yes.
What is your opinion on the electronic health record recording trans status, surgery status, revealing if it's necessary?
Well, I think the thing that's really, you know, really in development, I think people are still trying to understand how to do this into developing systems around organ inventory, because the question is really not, you know, exactly. I mean, we want to know what surgeries people have had, but we also want to know the organ inventory, because we don't want to send people the wrong screening letter. You know, I mean, people often are getting the wrong letter, like, oh, it's time for this screening, but that's not actually, they don't actually have those body parts. And so really, you know, we want to be sure we understand who people are, you know, not just in how to navigate the interactions appropriately, but also understanding medically what screenings would be helpful, what do they need to know. And so I think that's really the critical piece that needs to be more developed around SOGI data collection. It's not just understanding gender identity and sexual orientation and pronouns and the name they go by, but also understanding the organ inventory.
So thank you, everyone. And I want us to thank Willy Wilkinson again for.
Thank you. Thank you.
I also want to thank Dr. Imbasciani and his partner, George DiSalvo, for endowing this lectureship. And
I just want to say one thing, that thank you so much for the invitation. If you have any questions you want to ask me one-on-one, feel free. And I have one book if anyone wants a signed copy. So thank you. All right.